Hello, welcome to the EKG Guy, and welcome if this is your first time. I hope you're having a wonderful week, and thanks for joining us. So this week's EKG of the week, we have a 67-year-old male farmer presenting with substernal chest pain worsened with exertion. Okay, here's his presenting EKG. Okay, and then I want you to take a look and try to interpret it yourself. Okay, try to figure out the regularity, rate, rhythm origin, where's the rhythm actually originating from, ventricular axis, atrial conduction, atrial ventricular AV conduction, IV or intraventricular conduction waveform. So try to fill out those on the right. Okay, you can pause the video when you're ready, restart the video, and we'll go through this together. All right. So hopefully you had a chance to go through it yourself. Okay, so we have a 67-year-old male farmer presenting with substernal chest pain worsened with exertion. Okay, so first we want to know, what is the regularity of this rhythm? Okay, so this is how I want you to approach each EKG, and you'll have other people that have their own, style, but this is something that helps me not to miss anything. And so far it's worked pretty well. So the regularity of the rhythm, that's up here. Okay, so we want to look at the intervals here. And one of the easiest things is to take these R to R intervals. So here's one R wave, here's another, here's an R wave, here's an R wave. Okay, R waves are positive deflections of our QRS complexes. Okay, so an R to R intervals from one R wave to the next, that's an R to R interval. Here's the next one that follows, and so forth. Okay, and then you have another R wave, another R to R interval, and you can see that they vary in duration throughout. Okay, so this is an irregular rhythm, but because it's irregular, there's also you may notice that some of these are kind of grouped together. There's two here, 3 here, 2 here. Okay, so not so much regularity to it, so we would still call this an irregular rhythm in terms of the R waves or QRS complexes. Okay, but there are some other waves that are occurring more regularly, and those are the P waves. Okay, and the P waves are these here. Here's a P wave, here's another one. Okay, a P wave here, here, here. And if you were to measure these out, these would be all P waves. Okay, so from one P wave to the next, this is what we call our P to P interval. Okay, and that throughout all of these P waves are the same. So you're kind of dealing with an atrial rhythm that is regular, and then a ventricular rhythm that has some irregularity to it. So for the atrial, we'll call it A, and then ventricular V. Okay, the atrial will be regular, and then the ventricular, in this case, we'll call it irregular. Okay. So when finding the rate here, the next thing is a rate. We have probably two different rates we can find. The machine often gives you the ventricular rate, but it's good to know how to find that. And because we have two different rhythms that we're dealing with here, okay, or not so much rhythms, but two different rates, we have an atrial rate and a ventricular rate. We have to know, so let's just erase this here so we can start fresh. We have to know that this 12-lead ECG that we have in front of us from beginning to end, so from the beginning all the way to the end, represents 10 seconds. And 10 seconds times 6 is 60 seconds, and you should know that's 1 minute. And what that means is if you count the number of complexes, whether P waves to find the atrial rate, or QRS complexes, or T waves to find the ventricular rate, and multiply that by 6, you can get the rate and estimate in beats per minute. Okay, so same thing here. And because we're not dealing with both fully regular rhythms, we'll use this way, okay, to find the rate. There's other ways you can use when you're using a regular rhythm, but we won't go through that in this lecture. So in this case, let's find the atrial rate first. So we said here's one P wave, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Okay, so you would want to do 14 times 6. So let's do our math here. 14 times 6 is 24, and 84 is our rate. So an atrial rate of about 84 beats per minute. So we'll put atrial rate of 84 beats per minute. Okay, then we have a ventricular rate, and we'll count out these QRS complexes. So here's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so 10, and 10 times 6 is 60 beats per minute. So an average rate of 60 beats per minute. Remember, the machine will give you the rate, and what they calculated was 62 beats per minute for the ventricular rate. So quite close. Okay, a good estimate. All right, so hopefully that makes sense. So far we have two different rates that we found. We found the atrial. Remember, atrial rate, you want to use the P waves. Okay, ventricular rate, you want to use those QRS complexes. You could also use T waves because they represent ventricular depolarization. Okay, so next we want to look at the rhythm origin. Okay, where is the rhythm actually originating from? Well, we know that there are P waves present. Okay, and are the P waves associated with the QRS complexes? Well, it seems like this P wave comes here, there's one that follows, and there's a P wave, but then there's a P wave and then no beat. There's a P wave and the QRS, P wave and a QRS, P wave, no beat, okay, no QRS beat, P wave, QRS, P wave, QRS, P wave, QRS, P wave, and then a drop beat. Okay, so you can kind of see that throughout. So not every P wave is associated with a QRS complex, and that should make you think that we may be dealing with some sort of block here. Okay, so we will get to that in a minute. Now, one thing to note is that the rhythm is actually originating from the sinus node. Okay, and how do we know that? We know that it's a sinus rhythm because, remember, in sinus rhythm, if we have our box diagram here, here's our right atrium, right ventricle, and left ventricle. The sinus node is up here, okay, and conduction heads this way towards the AV node and then to the conduction system in the ventricles. So if we overlay the right atrium, which is this portion here, onto this, imagine that's our right atrium. Here's our sinus node, conduction's heading in this direction. Here's our lead 1, okay, AVF, lead 2, AVR, okay. So, and then we have our horizontal plane V4, V5, and V6. If the wave, which we have here, is heading in that direction, we should see upright P waves in those leads in sinus rhythm, if it's coming from the sinus node, and invert in AVR. So if we look here, we said that lead 1 has upright P waves that we see. Lead 2, the same thing. Lead AVF does as well. Okay, here's V4, you can see somewhat V5 and V6, and then AVR has these negative P waves. So in fact, we do have a rhythm that's originating from the sinus node. Okay, sinus rhythm, and the atrial rate's at 84 beats per minute. All right, but there's also some conduction delay that we'll get to in a moment. All right, so let's move on to the ventricular axis. Now, ventricular axis in adults normally is between -30 and positive 110 degrees. Okay, so let's just erase this here, clear it up. All right, so here we go. Now we have normal axis is between -30 and positive 110 degrees. Okay, now let's just orient ourselves here. Okay, if this is normal, this is left axis deviation, this is right axis deviation, and this is a northwest axis, or no man's land, okay, or superior rightward axis. Here's north and west, okay, that's why it's northwest axis. So what we have to know here is that lead 1 sits here, AVF is down here. Okay, there's many ways that you can use to find the ventricular axis, and we're going to use this way because it's easy to learn. Okay, so here's lead 1, here's AVF, okay, normal axis is here. Let's look at what lead 1 and AVF show. So lead 1, lead AVF. Notice our QRS complexes are mostly positive, okay? Mostly positive QRS complexes, which means we go towards the positive end of lead 1. Okay, this is the positive end of lead 1, positive end lead of AVF. Here is AVF, okay, and you'll notice that AVF is mostly negative, okay? Notice that this is mostly negative down here. So mostly negative, meaning we'll go away from AVF and go this way. Okay, that means our axis lies somewhere here, but now we need to determine which side of this line is, because we said this was normal over here, but this was left axis deviation. Okay, how do you do that? Well, you need to use another lead, and that lead is lead 2 that sits at positive 60 degrees. And why do we use lead 2? It's because here's lead 2, perpendicular to that is actually this lead here that goes to -30 degrees, which means that if lead 2 is positive, it'll be in this region here, okay? If lead 2 is negative, our axis will be over here, Okay, so if we look at lead 2 and you measure, here's baseline, here's the positive and negative. Okay, it's actually almost isoelectric. Okay, and it's isoelectric, meaning that it's pretty much on this line, on this negative 30 degrees. All right, so because of that, we have somewhat of a normal axis or borderline left axis deviation. Okay, so we can say borderline left axis deviation. All right, and because of that, the actual axis that the machine got was a negative 29 degrees. Okay, and negative 29 degrees would come pretty much right here, so slightly within that normal range. So we'll say normal for now. Okay, so normal in our adult male patient. Remember, this is adults. Children have a different axis ventricular because the right ventricle is the most dominant. Okay, especially at the end of the gestational period and early into the infancy period. Okay, before the left ventricle starts dominating. All right, so next we have atrial conduction, and this is where we look at the P waves. Are there any atrial abnormalities? Okay. Well, we looked at where the rhythms are originating, okay? But now I want to know, is there any left atrial or right atrial enlargement, okay? And the best leads to look at are leads 2 and V1. Okay, I'll erase this here as to not confuse you. So leads 2 and V1, and atrial abnormalities, that means we are looking at the P waves, okay? So with our P waves, okay, we're looking at these rhythms, and remember that the beginning of the P wave represents right atrial depolarization, and the terminal portion represents left atrial depolarization, okay? And what we do notice here, we won't get into all the details, but there is evidence of left atrial depolarization, okay? So in V1, you can see these biphasic P waves. The beginning of it represents the right atrial depolarizing, and this is the left atrium depolarizing. When we look for left atrial enlargement, we look at this portion. When we're looking at for right atrial enlargement, we look at the beginning, okay? And for left atrial enlargement, you want at least 1 millimeter wide and 1 millimeter deep, okay? And in that, it's hard to see here. I'll kind of erase that, but it is actually present there, okay? So we do make it there, but another lead to look at is lead 2 or any of the inferior leads, okay? Lead 2 is a good one to look at, and what you want to look for left atrial enlargement is something like this. From the peaks, from this peak to this peak, you should have at least 40 milliseconds in width, which is one small box, okay? And then from beginning to end of the P wave, it should be at least 120 milliseconds, which is 3 small boxes, okay? And if you were to see these or measure them out, you'd actually see some of that notching there, okay? Maybe you could see it better down in these leads. Hard to make out if you're not zooming in, but if you trust me, it is there. So we do have evidence of left atrial enlargement, okay? And in lead 2, the reason why you have it prolonged is because, remember, the terminal portion is the left atrium, and it'll push it this way. For right atrial enlargement, you're going to see peaking of these P waves in the inferior leads. All right, so now we have AV conduction. Okay, so there's a lot here in this EKG that you can already start to see. So AV conduction, we said that we have P waves, but there's some of them that are not followed by a QRS complex, meaning that we have dropped beats. Okay, and what we have here is a P wave, a dropped beat, a P wave, QRS, P wave, QRS combo, okay? P wave, dropped beat, there's a P wave and QRS, P wave and QRS, P wave, drop beat, P wave, QRS, P wave, QRS, P wave, QRS, P wave, drop beat, okay, and so forth. All right, and it seems like there's another drop beat here at the end. So what does this indicate? All right, so there's some sort of block going on, all right? And what you have to notice here, just erase some of these, is that these P wave, the PR interval, which if you look here, here's our QRS complex, the PR interval, which is from the beginning of our P wave to there, is actually constant when it's followed by a QRS complex, okay? So these PR intervals that you see here are constant when they're followed after a QRS complex. And why that's important is because if they weren't constant and you saw dropped beats, it could indicate a third degree AV block or a winky block. Okay, but because you have these constant PR intervals and then intermittently you have drop beats, this is what we call a second degree AV block, Mobitz type 2. Okay, so second degree AV block, and this is Mobitz 2. Okay, Mobitz 1 is winky block, where you have the longer drop, that meaning the PR interval gets lengthened and then you have a drop beat. Okay, but notice that this is not third degree AV block. You have P waves associated with QRS complexes. Okay, there is certainly association there. All right, so let's move on to IV conduction. IV conduction, I'm pretty much looking at these QRS complexes. IV meaning intraventricular. What is the conduction within the ventricle? So here you want to look at the duration of the QRS complex. Okay, and what normal duration is between 70 and 110 milliseconds, okay, or less than 3 small boxes. Once you start hitting 120 milliseconds or more, we start considering this abnormal. Okay, and I was reading another book today that even put it up to 100 milliseconds. So anyways, less than 120 milliseconds is what most references will consider normal, and we're going to stick to that. So here the machine gave us, instead of, it's hard to make it out on your own, is that the QRS duration or QRS interval was 128 milliseconds. So we would call that intraventricular conduction delay, okay, meaning there's delay within the intraventricular, the conduction within the ventricles, okay, and that can be from a bundle branch block that we may see here or some other things. So let's get moving on because there's still a lot to cover here. So we have some prolongation of the intraventricular conduction. Now let's look at the waveforms, okay? And this is where you're going to look for PR segment elevation or depression, which there is none, okay? Are there any abnormal Q waves, okay? Well, this patient presenting with substernal chest pain and worsened exertional symptoms, you want to look for ischemic symptoms or ischemic patterns on the EKG. And if you look here, these are deep abnormal Q waves in those anteroseptal leads, okay? In addition, you may notice that there is ST elevation, okay? So here's our baseline. You can see some ST elevation also in these leads, maybe even slightly there, okay? And flattening of them, okay? Those are ischemic signs. And because you have Q waves associated with ST elevation, this is most likely an acute infarct. Okay, so that's one thing to keep in mind. It's involving leads V1, V2, V3, and V4, which are the anteroseptal leads. Okay, notice in V5 you start to still see that R wave. Okay, so that's still expected and maybe not involving that region of the heart. So that's what I want you to see here, is that there's an anteroseptal infarct, okay, in those leads. And that's likely an acute, all right, not an old one, because you have associated ST elevation changes. Obviously, you want to look back at a prior EKG, and actually these are new changes. So that's one thing to keep in mind, okay, as well as the clinical context of all this is going on with this typical anginal pain that's worsening with exertion. All right, another pattern I want you to notice here, I told you there's a lot going on here, is a right bundle branch block. Okay, well, you may say, I don't see that rabbit ears pattern. Well, you have to know that even in the setting of an infarct, you can still have a right bundle branch block pattern. It does not obscure it. Where in left bundle branch blocks, we start thinking of using Scarbosa criteria or some other ways to identify it, because the left ventricle makes up most of the QRS complex. Okay, so what do I mean by a right bundle branch block pattern? Well, what you have going on here is a QR prime pattern, okay? Meaning that this R wave, the initial R wave that you tend to see, okay, with an RS, R prime pattern in a right bundle branch block is not present, okay? Instead, that initial R wave, okay, if you imagine here's your complex, that initial R wave is now pretty much dead and now inverted because of this infarct pattern. So whether it's an old or a new infarct, you can see this. Okay, so notice you have a QR wave. Okay, this R wave, this late R wave, that late vector that's coming towards the right ventricle, this late vector, okay, here that slurred S wave that we see here, okay, the prolongation of the QRS complex. This is a complete right bundle branch block pattern. So complete right bundle branch is present here as well. All right. Is there anything else? Well, we've hit on a lot, okay, already here with the ST elevation that we mentioned in the anteroseptal leads. Okay, so the ST elevation, the Q waves that were abnormal in those leads, V1 through V4. All right, so let's look at, there's nothing else here. I just want to make a comment on the QTC interval. Okay, the QTC interval was actually 345 milliseconds. Now, sometimes in infarcts, you can see this prolonged, but here it's normal in this male. Okay. All right, next we need to see, and why may this QTC interval recorded by the machine be a problem? Well, notice we have dropped QRS complexes, okay? And it usually takes into account the Bazet formula, which takes into account the R to R interval. And if you have these changing R to R intervals, it's hard to trust the EKG machine, and that's probably why it's so low. Okay, so again, you have to be aware of this as to not rely heavily on the machine. Okay, R wave progression. Well, in this case, this is in the precordial leads, these last two things. The R wave from V1 all the way up to V5 should increase in amplitude, but notice that this initial R wave is not there. There's not one in V2 or V3 or V4. We start to see it in V5 and V6. So this is what we call a poor R wave progression. Poor R wave progression, and that can be seen when you have lack of those anterior forces, like in the setting of an anteroseptal infarct. All right, so another thing that points to that. Where's the transitional zone? Meaning, where are the complexes going from being mostly negative to positive? Okay, well, it's hard to tell here because you have this big force coming to the right ventricle. Okay, but let's use these initial forces. I think that's the best to use here when you're looking at these last two R wave progression and transitional zone. So this is a big negative, okay? Negative, 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 and we say the transition's probably here, okay? So I would call this a late transition, okay? And late transition, also known as a clockwise rotation. Another thing that's pointing to this sort of anteroseptal infarct. So let's take this all together. Okay, now we have a regular atrial rhythm at a rate of 84 beats per minute in sinus rhythm. What does that tell you? That tells you that you're dealing with a normal sinus rhythm. Okay, now it's a normal sinus rhythm, but it is with a second degree AV block Mobitz type 2. Okay, I want you to notice that you can have normal sinus rhythm in the setting of an AV block. Okay, most books will not mention that. All right, they'll kind of skip over and they kind of separate the rhythms and call that. But I want you to notice that we have a normal sinus rhythm in a second degree AV block, Mobitz type 2. You have left atrial enlargement. Okay, we said that we have a complete right bundle branch block pattern, okay, and then we have an anteroseptal infarct, okay, and this is likely an acute, okay, because we saw that ST elevation associated with QAs, and obviously why I say that also is because I know that prior to this EKG, the patient only had a normal sinus rhythm. No block, no enlargement, okay, but this was taken a few years earlier, and he may have been lost to follow-up, or there haven't been a reason to get one in between there, okay? So we have a 67-year-old male farmer presenting with substernal chest pain, worsened with exertional, okay, actually relieved with rest. Nitro helped the pain in the emergency department. This is typical anginal chest pain, okay? Troponins were elevated, and the patient did have an LAD infarct, okay? So this EKG shows normal sinus rhythm with a second degree AV block, Mobitz type 2, left atrial enlargement, complete right bundle branch block pattern, and an anteroseptal infarct, okay? And this is likely an acute event, as we saw here. All right. Well, that's the end of this EKG of the week. I hope you learned something. Now I want to make you aware of our EKG coding reference that many of you are already using. How to get access, okay? So you want to go to this link here. So put in that link into into the computer, into your internet source, and then go to put your email address here when you get to that, and then you're going to use my password here to put in there. Make sure you're using my password every time, okay? And let me just erase here. So this one here, all lowercase, put that in, and then click submit. Confirm your email. So check your email, get a confirmation, and you'll have access, okay? And access here will be this, and you'll start to see that we have examples, and I'm now adding videos into it. So this is an on-the-go reference, has everything you could possibly imagine we use as we're building the course for our fellows here at Mayo Clinic, and so forth. So I think it's quite handy. Our techs are using it. We're using it for coding here as well. So very helpful way to learn, to use as a reference, and so forth. Okay, and you'll see a lot of the things we discussed in this lecture there as well. All right, so a few things. If you thought this was helpful, if you did, yes or no, I would like to know how I can improve, what kind of topics you want. Please leave them below. Like this video if you find this helpful, and share with friends. If you want more practice, okay, obviously more practice is on our Facebook page, where there's almost 500,000 of you there, and thank you for your support. We have daily questions, trying to get back to you between our clinics and making sure we're staying in touch. So go there for practice. There's daily practice. I leave resources. You can find us on Twitter, search the EKG Guy, YouTube obviously, and Facebook. Okay, it's hard to keep up with all these things, so find us there. Share with your friends if you find this helpful, and please leave a comment if there's any topic, or just kind words. We always appreciate it, and I hope you learned something today. Well, thank you for making us the largest, fastest growing EKG community in the world.